cancer and help patients and caregivers access the right treatment at the right time. Without much further ado, let me introduce our oncogenius to you so that he can enlighten us on today's topic, that is about kidney cancer. Dr. Krishnamani is a renowned medical oncologist with expertise in both solid and hematological malignancies. In addition to being a full-time clinician, he also has a keen interest in research and has participated in multiple clinical trials. His commitment to advancing the field of oncology is further demonstrated by his membership in American and European oncology societies. Currently, he is working at American Oncology Institute in Hyderabad. A very warm welcome to you, sir.
Hello and welcome everyone to Cancer Reach. Thank you so much. So Cancer Reach is an initiative to spread awareness about cancer, and today we chose kidney cancer because this is a kidney cancer awareness week or month. So we wanted to focus on this common cancer which is being detected in pretty early stages these days. So we wanted to talk about the symptoms, how we detect this disease, how we are going to treat this disease, etc.
So, can you begin by telling us what exactly is kidney cancer?
So, for layman terms, we would call it kidney cancer, but I would put it as renal cell carcinoma. Renal in medical language means kidney. So, a cancer which starts in the kidney is called a renal cell carcinoma or an RCC. R for renal, C for renal cell, and C for cell, and C for carcinoma. So any tumor or a cancer which starts in the kidney is an RCC or a kidney cancer. And most common cancers which come in the kidney are these RCCs. In this, when you look at it, the cell type, the most common type is called a clear cell RCC. So when a kidney cancer or RCC is seen by a pathologist in a microscope, the commonest variant or type is called a clear cell. The next common type is called a non-clear cell. So if you have 100 renal cell carcinomas, around 80-85 will be clear cell. Non-clear cell is a small minority. In non-clear cell, you have multiple types like papillary, chromophobe, medullary, collecting duct, sarcomatoid. These are not for a common man usage. It is not for our regular discussion. These are specific subtypes of renal carcinoma given by a pathologist when the tumor is seen under the microscope. So for layman terms, cancer which starts in the kidney is RCC. Most common tumor is RCC. Rarely you can have other tumors like TCC, lymphoma, etc. But kidney cancer means RCC. In RCC, most common is clear cell RCC. This much, if you remember, more than enough.
And so, what causes renal cell carcinoma or what causes kidney cancer?
Smoking, most important factor. Obesity, hypertension. Okay? These are the three most important and reversible factors. Stop smoking, keep your blood pressure under control, and have a good control on your weight, obesity, so that these three factors can be controlled. Then sometimes patients who are on end stage renal disease, who are on chronic dialysis, they can develop kidney tumors. Some patients have multiple cysts on their kidney called polycystic kidney disease. They can develop kidney cancer. And in some patients, it is hereditary. There are certain syndromes. Syndromes means a patient has a set of clinical features. So some common syndromes which can cause RCC are Burt-Hugh-Dubé syndrome, we call it, BHD, VHL, von Hippel-Lindau syndrome, SDH deficiency, fumarate hydratase deficiency. So rather than going into specifics, what you should understand is smoking, obesity, hypertension, chronic kidney disease, patients who have multiple cysts in their kidney, polycystic kidney disease, adult polycystic kidney disease, and certain hereditary causes of kidney cancer. So these are the 5 to 6 most important factors which cause RCC.
And so, coming to the syndromes that you have spoken about, is it common in Indian population? Do you see a lot of such patients with the syndromes having kidney cancer?
It is not common. They're very rare, but you should try to think of a syndromic association when multiple people in the family are affected, when young people are affected, when both the sides kidneys are affected. Okay. So, or when somebody has already been diagnosed in the family with a hereditary syndrome, that is when you will start thinking. Tomorrow, every patient of RCC, you start thinking about hereditary. No, common things are common.
Any gender predilection, like is it more in females or is it more in males? Any sort of such leaning?
Generally, the male female ratio, it is more towards the men.
Okay. And so, like, what are the typical symptoms that we should look out for?
See, the classical teaching was when we were medical students 20 years back was uh, blood in the urine, pain in the flank. Flank means the lower part of your, the sides to your abdomen. Okay, pain in the flank, bleeding in the urine, a mass in the flank. If you see some lump in the flank, these are all the common signs. If the disease spreads to other areas, suppose it goes to brain, you may have headache, you may have a paralysis, you may have fits, seizures. If the disease goes to lung, you may have water in the lung and you may have breathing difficulty. Disease goes to liver, you may develop jaundice. So this is because of spread. So this is the classical teaching. Today, most patients are asymptomatic. That is, they don't have symptoms. Why? All of us have master health checkups. Every year we go and get an ultrasound abdomen. So many patients, they don't have symptoms. They get master health checkups or ultrasounds or CT scans done. That picks up a kidney tumor even before the patient develops symptoms. So that is called incidentally detected masses. So incidentally, or you go for something and this comes up. It is like woman getting ultrasound of the breast. She doesn't feel a breast lump, but the ultrasound says you have something in the breast. Then you do biopsy, you say it is breast cancer. Same way. So nowadays, because of widespread use of ultrasound and other imaging and lot of access, even in a small village, even in a town, you have ultrasound. You put the ultrasound probe, the doctor will say, oh, you have a swelling in your kidney or a tumor in your kidney, go and meet an oncologist or somebody else, not a surgeon. Patient is asymptomatic. That is why what is happening is you are finding smaller tumors now. If you have to develop symptoms, the size should become big. It should form a lump. It should bleed. You have no symptom. You are picking it up on ultrasound or CT, and they are very small. So, because of widespread use of ultrasound, asymptomatic patients with small kidney tumors are being detected early now, at an earlier stage.
And sir, how do you evaluate or diagnose it?
So, any solid tumor in the kidney is considered an RCC unless proven otherwise. So, what the statement means is if if you have a tumor or a solid mass in the kidney, you should consider it as kidney cancer. Biopsy is usually not recommended if it is localized or if it has not spread. So you will do an ultrasound of the CT first. CT is enough. Sometimes we also do a PET CT. If the tumor is localized to the kidney, usually for kidney cancers or RCCs, we don't biopsy. If it is localized, we send it to the surgeon for a removal, which can be either partial removal of the kidney or total removal of the kidney. If the disease has spread to other areas like lung, liver, etc., you will biopsy those areas, prove it is RCC which has spread, prove it is stage 4, and then you will go ahead. Am I audible?
Yes, sir.
Hello?
Hello, just a moment, sir. Just a moment.
So, sir, you were talking about the surgery. How many of the patients actually go for surgery upfront?
It depends on, so all those patients who are localized should undergo surgery. And as I told you, the surgery is either a partial nephrectomy or a total nephrectomy. Sometimes when you have metastasis also, you send the patient for surgery if the metastases are in one or few areas. That is, we call oligometastatic. Sometimes, even if it spreads to many areas, you may do a surgery for the tumor because it is bleeding, because it is extremely painful. Otherwise, with frank metastasis, you usually don't advise surgery to the primary tumor.
Okay, sir.
So, what about the treatment options for kidney cancer patients?
So the treatment options are based whether you are localized or metastatic. If you are localized, as I told you, surgery is the treatment. It could be partial removal of the kidney or complete removal of the kidney. If it has spread to other organs, you go for immunotherapy. Chemotherapy is not used in this disease usually. This is one disease in which immunotherapy works very well. So in stage 4, advanced kidney cancer, which is spread to many organs, treatment of choice is immunotherapy. In earlier stages or localized disease, the treatment of choice is surgery. After surgery, for localized disease, we give immunotherapy called adjuvant immunotherapy so that the disease doesn't come back in a few patients who have a high risk of recurrence. That is, surgery is done, you look at the pathology report, there are some factors in that. If the chances of disease coming back are low risk of recurrence, no treatment is required after that. If high chances of recurrence are there, based on grade, etc., then you say take immunotherapy after surgery so that disease doesn't come back. Now, coming to the other end of the spectrum, you have stage 4 advanced disease spread to all areas. Your treatment is immunotherapy with TKI. TKI means tyrosine kinase inhibitor. So some examples are a drug called pembrolizumab plus axitinib, or pembrolizumab plus lenvatinib, or nivolumab plus cabozantinib. So chemo is not generally used. We use immuno plus tablets or TKI. Also in stage 4, you categorize patients as good, intermediate, and poor risk. Why? Good risk patients usually live for around 4 years, average survival. Poor risk live for average of 6 to 8 months only. And what are the factors you take to divide somebody into good, intermediate, and poor? Their hemoglobin, their WBC, their platelet count, their general condition, age, etc. So, chemo is generally not used. You use immuno and tablet combination. You divide stage 4 patients into good, intermediate, and poor risk based on hemoglobin, WBC, platelet count, and general condition. Good risk patients live for 4 years and beyond. Poor risk patients have a survival of less than 8 to 9 months.
And for poor risk patients, is there any other support that we can give? Because the survival rate for them is very small.
This is
Has
the
there
treatment
been
of choice. Once the disease progresses, you would go for another set of treatment. Suppose somebody progresses on pembrolizumab plus lenvatinib, you will go for another TKI, for example, pazopanib or axitinib or sunitinib, etc. But then your options are limited. You are juggling between your options.
okay?
Your aim in stage 4 is quality of life, improve symptoms, and prolong life if possible.
And sir, since you have mentioned immunotherapy, like can you explain or elaborate a little bit more about the role of immunotherapy and the molecules which are being used?
So see, chemo is generally not used in this cancer. Immunotherapy means a medicine boosting your immunity to kill the cancer. The names I told you, a drug called pembrolizumab, drug called nivolumab, so what happens is when the cell and the tumor, your body cell and tumor interact with multiple antennae in between. Some of them are called PD1, PDL1, etc. So these medicines block that interaction and kill the tumor cell. It's a very simplistic way of putting it. So for a common man, immunotherapy means it boosts your immunity, it kills your cancer, and it's an injection given in a saline bottle once every 3 weeks or once every 2 weeks. You would give it for 6-7 cycles. You scan the patient. If the disease is coming down, it means the medicine is working. Then you will continue the immunotherapy. How long? In stage 4, maximum we give it for 2 years. The side effects of immunotherapy are patients can develop skin reactions called dermatitis. They can develop thyroid problems, hypothyroidism. They can develop pancreatic issues. They can develop liver enzyme fluctuations. Less than 5% patients can develop pneumonitis or lung changes. Okay. Arthritis, colitis, that is intestinal problems. So immunotherapy can lead to itis. Itis means inflammation top to down. It may not lead to hair fall, severe vomiting and all that, but it can lead to fatigue, hypothyroidism, pancreatic issues, thyroid issues, liver issues, skin issues, gut issues. But generally very safe, very well tolerated, patients do well. And those patients who do well on immunotherapy do well for a longer period of time.
So, is immunotherapy like a game changer for kidney cancer patients?
Yes. And today it is the standard of care.
And sir, these two drugs, is there any particular instance or a situation or maybe a specific condition where you would use one over the other or vice versa?
Nothing like that.
Okay, sir. And sir, coming to the nutrition part of it, like whenever a patient is on dialysis, like you said, chronic dialysis patients are at a higher risk to develop the kidney cancer. So, is the nutrition for the patient limited for all kidney cancer patients? I'm asking from the nutritional aspect.
The salt restriction is always advised. Fluid restriction is advised by your nephrologist because there is water accumulation in the body. Salt restriction is advised. It also controls your blood pressures. High protein diet is, or a medium protein, moderate protein diet is advised so that the muscle mass doesn't fall. Otherwise, from a cancer point of view, we don't give restrictions per se. When you're in immunotherapy, patients are not put on steroids. That is one thing they should understand. They may have skin problems or arthritis and all that. So your steroids, ideally, they should avoid steroids. Okay. So these are all the things which we should bear in mind.
And sir, any specific message for caretakers of kidney patients that you would like to give?
If you're already on treatment, continue your treatment properly. Nowadays, good support programs are available for immunotherapy, though they are expensive. Now they become much affordable. So finance should not be an issue. If you're a patient who's been operated for kidney cancer, please be under regular follow-up. Every 3 to 6 months, you'll be asked to do periodically some X-ray or ultrasound to see if the disease is coming back. If you have a family history of somebody with kidney cancer, please consult your doctor for any hereditary cancer syndromes. And the general public, smoking, obesity, hypertension, I think we should be able to control so that we are able to detect or we are able to prevent kidney cancers.
Okay, sir. Sir, any parting words before?
So to just sum up, it's a common cancer. We are detecting it early nowadays because of rampant use of imaging like ultrasound or CT scans. Luckily, we are picking up at an early stage, so the prognosis is extremely good. Surgery is a treatment for localized, for metastatic disease also. If it is only few places or oligometastatic surgery for the kidney is still recommended. Surgery is also done if you have severe pain or severe bleeding. It could be partial removal or complete removal of the kidney. Immunotherapy is given in certain patients after surgery based on the risk of recurrence. And for stage 4 advanced cancer, immunotherapy plus TKI is the treatment of choice. And this has to be continued for a period of 2 years if they are doing well, at least.
Okay, sir.
Session. Done.
The recording is live.
Yeah, it is. So you can ask me if there's anything. If it's done, so we can.
Sir, shall we wrap up this
Yeah,
session?
please. I think with that we've almost come
Covered
to
the.
an end and we've covered most aspects of kidney cancer.
Yes, sir. Yes, sir. So thank you for your time, sir. And we
Thanks.
hope to see you again next Friday.
Thank you so much.
Thank you, sir.